Good morning. My name is Stavros Loukogeorgakis, and I'm a pediatric surgeon representing a multidisciplinary team from Great Ormond Street Hospital in London. Thank you for the opportunity to present our work. We have no disclosures. Nephrectomy during surgery for high-risk neuroblastoma limits options for subsequent adjuvant chemotherapy. In our institution, high-risk neuroblastoma patients typically undergo surgery within 5 weeks of Cohort induction chemotherapy as per protocol, but some patients who are deemed to be at high risk of nephrectomy undergo planned delay surgery after high-dose chemotherapy. The aim of our study was to assess if planned, delayed, or deferred surgery impacted outcomes in patients with high-risk neuroblastoma. We performed a retrospective review of our cohort of high-risk neuroblastoma patients between January 2008 and December 2019. We identified patients who had surgery as per protocol, as well as deferred surgery, but patients who had surgery delayed due to poor response to Cohort chemotherapy were excluded. We looked into outcomes, including intraoperative and postoperative complications, as well as event-free and overall survival. This is a summary of our patient cohort in groups. We had a total of 84 patients. There were 49 patients in the surgery as per protocol group, 22 patients in the deferred surgery group, and 13 patients were excluded due to poor response to Cohort. This is a summary of our patient characteristics. You can see that there were no significant differences between the groups in the proportion of male and female patients, as well as mean age and median number of imaging-defined risk factors. The time from Cohort to surgery in the surgery as per protocol group was approximately 6.5 weeks, but it was significantly longer in the delayed or deferred surgery group at 27.5 weeks. This is a summary of our perioperative outcomes. There were no significant differences in the proportion of patients that had complete resection of their tumors. There were also no differences in intraoperative as well as postoperative complications and the requirement for additional surgery. This is a breakdown of intraoperative complications. It is important to point out that none of our patients in neither of the groups had unplanned nephrectomies. There were no differences between the groups in major bleeding during the operation, defined as blood loss of more than 300 mils. There was no difference in major vessel damage as well as bowel damage, and none of our patients required formation of stoma. This is a breakdown of the postoperative complications, and as you can see, there were no differences between the groups in the incidence of bowel obstructions or nosocomial infection, and none of our patients had wound infections or dehiscence. We looked at event-free survival, and we discovered that our 5-year event-free survival for the surgery as per protocol group was 61%, and the event-free survival in the delayed or deferred surgery group was 59%. There was no statistically significant difference between the groups. Similar results were observed in overall survival, with our surgery as per protocol patients having a 5-year overall survival of 71%, and our deferred surgery patients having a 5-year overall survival of 64%. Once again, there were no statistically significant differences between the groups. In conclusion, surgery for high-risk neuroblastoma can be deferred until after high-dose chemotherapy to mitigate the risk of intraoperative renal injury with no effect on resectability, perioperative, as well as long-term outcomes. I would like to thank you very much for your attention.